Thank you, Dr. Ritesh, for giving me the opportunity to present at this podium. So the topic that I've been given is breaking the obesity cycle with orlistat, and I'll try to present the new data as I have. Just a very brief overview of what are the current thoughts for obesity. So we have multiple theories. The most common is the SICO hypothesis, which is calorie in, calorie out. You have a lot of food plethora, you end up being lazy, you don't exert that much. The calorie excess is going to manifest as obesity. Then you have these epigenetic modifications that have come up with various eponyms like you are what your mother ate and Dutch hunter winter Fleming. I can discuss this later on if anybody is interested in discussing these modifications effect. And then you have environmental factors like stress, disrupted circadian rhythm, gut microbiome, obesinogens like endocrine disrupting chemicals, etc. But at the end of it, what obesity is, in a very, very basic term, it's a neurobiologically where we have two systems that govern eating. We have a reward system which stimulates feeding, and we have a satiety system which inhibits feeding. The problem is, if anytime we try to interfere with this pathway, it's going to affect the hedonistic areas, the reward pathways, and this is going to have a psychological side effects. And I'm going to come back to it, so just keep a note of here. And if you try to make it a little bit complicated, you will find that there are multiple peripheral inputs that are converging on the central pathways, and because of this we have an organized orchestra which ultimately leads to obesity. Why are we talking about this? Because the epidemiology is looking very bad. The US is somewhere around 37%. India and Japan seems to be doing pretty well, but are we really doing that well? Because from 1975, when we had less than 0.5% persons as obese, till 2016, as the graph goes, the obesity was more than 3.5%. And this is the graph for BMI more than 30. We are not talking about what is happening to BMI more than 25, which is what is actually we take as an Indian criteria. So what's happening at BMI more than 25? This is the latest paper by Anjana published in Lancet, and we must have all seen this. This has been making rounds day in and day out. So 28.6% is what we have generalized obesity, in which they took the criteria as BMI more than 25. And everything is red, especially when we compare the urban areas when it comes to generalized obesities or the abdominal obesities. The urban is all red, rural is catching up to us. So we have a lot of epidemiology, we have a ticking time bomb in our hand, and we need to do something. So we had a lot of drugs that have been developed over the timelines, starting from 1933 till 2021 when semaglutide was approved, and now we have tirzepatide also being approved. But one thing that I want you to notice is that as the drugs were approved, so the drugs were withdrawn. Rainbow pills approved, rainbow pills withdrawn. Phentermine approved, phentermine withdrawn. Everything, as the drugs are being approved, so are they being withdrawn. And why are they so? Why are the drugs getting approved? Because of the curse of the weight loss drugs. They are doomed by their nature, because majority of the drugs, they act at CNS, they affect the hedonistic pathways. From amphetamine to lorcaserin, they have all been withdrawn subsequently. And GLP-1s are also facing the similar issues. I mean, if you look at the FDA's adverse events reporting system, as of today, 489 adverse events have been reported regarding the psychological manifestations of semaglutide. So we needed a new drug, and it's not a new drug, it's an old drug that's been making a comeback or the sorts. Because orlistat mechanism of action, it's a non-CNS acting, locally acting drug. It inhibits the intestinal lipase inhibitors, so the fat molecules are not broken down into free fatty acids and they are not absorbed because orlistat binds with the pancreatic lipase. FDA indications BMI more than 30 kg per meter square or more than 27 if you have another risk factors of metabolism or obesity, and also they've added a new category as reduction of risk for weight regains after prior weight loss, specifically after they've been considering it for bariatric surgeries. Dosing is 60 to 120 milligrams twice a day. You can take it with or within 1 hour of the meal. Pharmacokinetics, onset of action takes a couple of days. Duration is around 2 to 3 days. Minimal absorption because it's locally acting. And excretion is by feces. Pediatric, more than 8 years, we have limited data that says that it is safe. Renal, it is safe. Hepatobiliary, it needs to be cautioned in patients with obstructed bile ducts. Pregnancy contraindicated, breastfeeding not to be used. Major side effects are gastrointestinal because the fats are not absorbed, so you're going to have fatty, oily stools, you're going to have fecal urgency or increased flatus with discharge. And these gastrointestinal side effects are the main reason for discontinuation of therapy. However, these are mild to moderate and they tend to decrease the longer you tend to use the drugs. One major side effects is that because it leads to fat malabsorption, so the fat soluble vitamins are also going to get malabsorbed. So theoretically, there is a risk of vitamin D related osteoporosis. Hepatotoxicity has been documented. I think when I was doing my research, it was somewhere around 10 cases have been documented of fulminant hepatitis, and the postulate is that it's usually hypersensitive because again it's not getting absorbed, so we don't know why it actually leads to that. Renal side effects minimal, but what happens is that because the fat is unabsorbed fat is there, so it ends up binding with calcium, because of which oxalate ends up getting free. A lot of oxalate is absorbed, they end up forming an oxalate stone, so this leads to renal decline. Cost effective analysis, basically a meta-analysis that was done, they found that numbers needed to treat to gain one quality of life was estimated to be 35. And based on a lot of assumptions, they calculated the cost, incremental cost per quality of life gained was somewhere around $11,000 to $35,000. And they concluded that this may still be effective if we continue the treatment only in patients who have shown effect at 3 months. Otherwise, it's better to stop the drug then and there. So just a preview, what we already know. Orlistat 60 mg to 120 mg results in significant weight loss in overweight as well as obese adults. It reduces leptin and increases ghrelin levels in obese patients, which ultimately leads to decrease in, which ultimately ends up affecting the neurohormonal cycles. And it has demonstrated a significant decrease in visceral adipose tissues, and it is effective in patients with binge eating disorder. So this we already knew. And a very simple study, a very important study was the Setu study in 2004. It was a 4-year double-blinded RCT, the longest duration that we have. It included 30 to 60 years old with BMI more than 30 kgs per meter square, and they were put on calorie reducing diet around 800 kilocalories plus orlistat or placebo. What they found was that there was a significant difference. The graph started diverging at 1 year, and the mean loss at 4 years was significantly greater with orlistat, which was statistically significant. Also in the same study, they ended up finding that at 4 years, incidence of diabetes was 9% with orlistat as compared to 6.2% with placebo. And there was a relative risk of 37.3%, but when they did further exploratory analysis, they found that this particular finding was mainly driven by the patients who had impaired glucose tolerance. So this was the 2004 study. But now what is the new data that we have? And for the definition of new, I took it as last 3 years. So orlistat and metabolic syndrome, this was a retrospective study, 200 patients on metformin. Basically, just showing you the table that when we looked at the lipid profile, there was a clear difference that orlistat after a treatment of 24 weeks tend to show improvement in the lipid profile. Not much improvement in systolic blood pressure or BMI, but in rest of the lipid parameters, yes, it does work. Orlistat for metabolic associated fatty liver disease, because when we talk about obesity in 2023, how can we not talk about metabolic fatty liver? So it was an RCT, 18 years Asian, more than 18 years Asian with BMI of 25, without 3% weight loss at 6 months with their best effort, who had underlying metabolic associated fatty liver. So they had 3 arms. They took conventional energy restricted diet. On top of that, they added an orlistat, and then they had another diet which they had specifically planned. And they did MRI PDFF, this is proton diffusion fraction for fat, which is a Dixon sequence before and after intervention, and what they wanted to look at was the liver fat change at 24 weeks. So what they found that in intention to treat and per protocol analysis, orlistat seemed to do better in terms of weight, in terms of BMI, in terms of weight equivalence. There was clear difference, and all of these were statistically significant. But when they looked at the primary objective, they found that in the intention to treat and per protocol analysis, percentage of patients who had more than 30% relative reduction in the liver fat change was still higher in orlistat, and there were people in orlistat who ended up developing no steatosis at 24 weeks. And if you look at the orlistat arms, this is the liver fat pictogram showing that this was somewhere around 20%, but at 24 weeks the liver fat content became almost 0. So yes, the orlistat had a lot of effect on the MRI associated markers for metabolic associated fatty liver disease. Then what is happening with orlistat with ecautos? So this was another trial that was published in 2022. It was again an RCT. They took a modified release fixed dose combination of orlistat and ecautos, and they named it EMD16. So it was designed to deliver both the drugs with distinct release rates in different GI compartments, and they hypothesized that because there is different and distinct release rates of both the drugs, there would be a reduction in the GI side effect as well as an increased synergism. Orlistat is going to impact your absorption of fat, acarbose is going to impact your absorption of carbohydrates, so overall the calories is going to come down. And then based on that, the endpoint was to check for the relative body weight at 26 weeks. And they had the 3 arms. One was a EMP16 120 by 40. 120 was your orlistat, 40 was acarbose, then the other was 150 50, and the third arm was a placebo. And what they found was that as compared to placebo, there was a significant decrease. As the time went by, the relative weight started to decrease. And the more than 5% weight loss in number of patients or percentage of patients who achieved that was significant in patients who were on the experimental drug as compared to placebo. Even more than 10% weight loss was achieved in around 20% patients. Then we have a newer modality, orlistat mouth rinse. It was published in 2021. The hypothesis, and this is very interesting hypothesis, what they found that obese have higher taste preference for fat, and orlistat locally can inhibit lingual lipase. So whatever food you are eating, if it has a lot of fat and the lingual lipase is not able to break down, the free fatty acids are not gonna scintillate your lingual fat receptors. If they are not activated, you end up not enjoying the meal as much, and so your preference for your high fat feeds might go down, because of which your calorie might reduce. So with this novel idea, they constructed a 24 milligram per ml orlistat solution of water. They compared it with just plain water, and they compared it with plain water, and they asked the patient to take this mouth rinse just before they are consuming their high fat diet. So in the initial arms, to their detection, they found that total calories were not very different. Total fat, total calories were not very significant. But then they did a sub-analysis, and they found that patients who were high-fat consumers, who technically had a preference for high fat, once they started using orlistat, their meal intake started to go down. So this was statistically significant in between groups, or also between the groups and in between groups. And then what about orlistat and CVD? So this was a poster presentation. This was the only data around cardiovascular death that I could find. It was a retrospective data of around 36,000, 37,000 patients with obesity match 1:1, and they compared taken orlistat versus not. Duration was not mentioned in the poster, so I don't know. But what they have said that at 6-year follow-up, the primary endpoint was 3-point MACE, and secondary endpoint was new onset heart failure and CKD. And the usage led to decrease in MI, stroke, new onset heart failure, mortality, and progression to CKD3, and all of them were statistically significant. The hazard ratio was quite low, with the 95% confidence interval not crossing 1, and all of these data were showing statistical significance. Last slide, orlistat and uric acid, because obesity, metabolic syndrome, we can talk about uric acid. Whether it has an impact or not is up to the debate. So just the forest plot showing that yes, at the end, orlistat seems to be reducing uric acid. What it's going to manifest is up to the debate. So the take-home message is that obesity is rising pandemic. We have to brace for the worsening of it. Multiple checkpoints in the pathways of diet and cessation is being manipulated, but side effects are expected if you tamper with the reward pathway. We've seen this through 1933. Orlistat is a GI acting drug with GI side effects with modest effectiveness, and for us, it's the only approved drug for obesity in India. So no matter what we use as off-label, this is still the only on-label drug that we have. Effects on metabolic syndrome are being explored with positive findings, and newer formulations are on the horizon that may further utilize this drug. Thank you.
Dr. Setu, for